I am now really pleased to get to introduce our keynote speaker, Dr. Kathy Wisner. As many of you know, Dr. Wisner is a pioneer in the field of perinatal psychiatry and has been accomplishing many things, including leading what is still the largest research study to date to identify the types of mood disorders and their onset during the perinatal period. She's an expert in benefit harm decision-making for psychopharmacology during pregnancy and lactation, and the mechanisms of maternal suicide and more. She's received over $22 million in funding from the NIH, published over 270 peer-reviewed publications, book chapters, and more, and is also notably the founder and was the president of the Marseille Society of North America. That's the nonprofit organization that leads research in this space and has many dedicated leaders. Some of you are in this room. She's also mentoring young scientists, which we're so appreciative of, including a couple of folks on our team who will be on the stage today. Dr. Wisner, we are so thrilled to welcome you back to the forum stage.
Well, Emily, you are a hard act to follow. That was so powerful. Thank you. And thank you, Joy, for the lovely introduction. The title of my talk is Maternal Mental Health is Fundamental to the Future Health of Our Population. I have no, it doesn't seem to be advancing. There we go. I have no conflicts of interest. And I wanted to focus on 5 areas that reflect our thinking in perinatal mental health, particularly perinatal psychiatry currently. 5 facts that, or 5 areas that position us well to continue to improve perinatal mental health. The first is the thinking about social determinants of health and incorporating them into our very definition of healthcare. So in this chart, which is from the CDC, you can see traditional healthcare accounts for about 20% of population health. So that, going to a healthcare professional, getting a diagnosis, treatment, contributes a relatively small amount to population health. And it's factors like the patient's behaviors, the environment, and the social determinants, housing security, food security, violence, that contribute to health. So we need to include these factors that impact health into our definition of health care. And in fact, we're seeing now social determinants of health being recorded in medical records. And some places like the UK have social prescribing. So again, we're attending much more to social determinants. We also need to think about the evolution of maternal mental health screening practices, the impact of developmental origins of health and disease on maternal health care, the sophistication of our observational data to separate the effects of the disease from the medications used to treat it on exposures, and finally, improving maternal mental health pharmacologic treatment and outcome, which is an incredibly important adjunct to the skill-building, supportive, and other kinds of therapies we offer to patients. So over the past few years, we have seen these headlines that are data from the maternal mortality review committees, statewide organizations, some people in this room participate on those committees, that have shown us that maternal mental health conditions are the leading cause of death in the perinatal period. If you look at this chart, you see that maternal mental health conditions are the most common, but also twice as common as things like postpartum hemorrhage, which Emily described for us, and other diseases in pregnancy. The other way that illnesses like mental health conditions contribute besides suicide and intentional and unintentional overdoses is that the rate of all of these other illnesses that we're looking at in this chart occur at greater frequencies in women with depression. The other issue that these data show us are the disparities. More than 2.5 times a higher rate of mortality for non-Hispanic, for Black, compared to non-Hispanic white women. We also learned that the later part of the postpartum period, say 7 days to the remainder of the postpartum period, are when most of the deaths occur. And sadly, and a reason for us to take action, is that 80% of these deaths in our mothers of the next generation are preventable. So ACOG has the statement listed here that these illnesses are important and significant patient safety issues. So years ago, I did this study in which I screened 10,000 women. These were not women selected for any kind of illness. They were 10,000 deliveries in Pittsburgh in the maternity hospital that serves most of the population of that city. We asked women if they wanted to be screened by phone 4 to 6 weeks after birth. And we used the Edinburgh Depression Scale. And we went to their homes if they screened positive and did a systematic diagnostic assessment. In this population, 1 of 7, 14% of women screened positive, and had we extended our evaluation time across the first year, it would have been more likely closer to 20%, 1 out of 5 women. So our challenge here is huge. Organizing in identification, treatment, and community-based resources for this large population of women. When we ask the women, when did this episode that you're being screened for and identified as positive now, when did it begin? A quarter of the women said it began prior to pregnancy. I had it long term, which means that we missed the opportunity to intervene with those women throughout pregnancy. About a third of women said it began in the 9-month pregnancy period. And the majority of women said it began from birth to that 4 to 6 week period. So this, again, majority of cases occurring after birth, when we have the stress, the hormonal change, all of the adaptations required, pain, physical recovery in that period, being stressors in addition to others that provoke episodes of postpartum depression. The other thing we saw was the disparities, that our screen-positive mothers were younger, women of color, had less education, more likely to have public insurance, and were not partnered. Again, sort of a cumulative disadvantage, stress, and greater episodes of depression frequency. When we evaluated the diagnoses of these moms, what we found very sadly was that these were not, by and large, first episodes, but recurrent episodes of depression. And many of the women said, oh, I've had anxiety since childhood. And I began having anxiety disorders, panic disorder, PTSD, and then the depressive episodes became recurrent. And now I have another depressive episode. So our renaming perinatal mood and anxiety disorders is very appropriate, because the reality is mood and anxiety disorders are incredibly commingled in this period, particularly PTSD, OCD, panic disorder, and GAD often beginning early in childhood. The other finding that was important was 20% of the screen positive for depression women had bipolar spectrum disorder. And this is important because handing a prescription to a woman with bipolar disorder risks worsening of her episode, risks agitation. And we also know that bipolar disorder is typically the disorder associated with postpartum psychosis. We also evaluated suicidality in this group of women. So on the EPDS, we have, on the EPDS, we have the thought of harming myself has occurred to me. We have never, hardly ever, sometimes, and yes, quite often, So they are color-coded, and you can see that if you screen with an EPDS score of 10 or more, about 20% of women will have one of those three scores. We really worry more about sometimes and yes, quite often. So I've put there about 5% of patients will require more questioning after taking the EPDS at the score of 10 or more. In clinical settings for 13 or more, about 10% of women endorse sometimes or yes, quite often. So thinking about assessing suicidality is an important part of our work. I put a QR code here for a lecture that my colleague Bree Court did. It's a wonderful lecture specific to engaging patients and managing suicidality with them, and it's free. So how do we distinguish unipolar from bipolar depression? Again, I worried about this because we are asking many people to screen for depression, not only perinatal, but depression in general. And in those screen positive patients is a subset of people with bipolar disorder. And if the evaluation's cursory and the diagnosis is not made, we've seen many instances of worsening agitation, suicide attempts from a patient with this disorder being prescribed an unopposed antidepressant. So again, this is a common and difficult problem in psychiatry. It is difficult often to make the diagnosis, and most patients with bipolar disorder have an initial mood episode and wait 7 years for their bipolar diagnosis. So how do we manage this situation? So we did, in this same screening study, we added this measure, which is the MDQ. It's basically a set of 13 symptoms of hypomania, mania. Racing thoughts, agitation, thoughts moving so quickly it's hard to speak. Speaking real fast so hard it's hard even. So energized, activated, plugged in, wired is how patients often describe it. 7 of those symptoms is a positive. They need to occur at the same period of time and produce an episode. You'll see that there's an X in that box to look at the self-assessed functional impairment due to disorder, and I'll explain why in a minute. The bottom part is family history or personal history of being diagnosed with bipolar disorder. So this is assessment that we evaluated, and what we did was we asked those patients with EPDS positive scores to fill out a mood disorder questionnaire at the level of screening. When our home visitors went to their homes to do the diagnostic assessment blind to the MDQ findings, we then said, okay, how good is the MDQ as a screen in identifying the diagnosis of bipolar disorder that was made at the home visit? When we used the complete measure with moderate being scored in the functional assessment, we identified 50% of patients with bipolar illness. When we ignored that item altogether, and we did just again ignored it and scored the measure, we were able to pick up 70% of patients that had bipolar disorder at the screening level. So this is an important measure, and my rule is if you're going to prescribe an antidepressant, before you write the script, you do an MDQ. There is a newer tool that's a 6-item rapid mood screener that is not tested, however, in the perinatal population, but many of my colleagues are now using that measure. So I also looked at the rates of abuse in the mothers with these diagnoses, and I was struck particularly for those women with bipolar disorder. Look at these rates. Sexual abuse as a child, 44%. Physical abuse as an adult, 53%. The rates are high across diagnosis, but it makes you think about what is the role of abuse in creating and facilitating these diagnoses. It also, I seem to be having a little bit of throat thing. Anyway, it seems to be an important factor that interacts with genes and environment to produce maybe HPA axis diagnostic risk across time. And it also has been very helpful in, oh, thank you. Thanks, Joy. Trauma-informed therapy, developing methods, as well as shorter PTSD treatments such as written exposure therapy. So throughout my career, what I've noticed is that drug therapy, the risks are always weighted more heavily than psychiatric illness, but they come together. Nobody would prescribe a med without a psychiatric illness. And the way developmental origins of health and disease have helped us is that there's now a focus on the importance of maternal health because the milieu in which that embryo fetus exists and develops has major effects on the evolution of its organs. And all of the milieu in which the mother exists, all of those social determinants, her overall health, are factors that interact with the fetus's genetics and the fetus's, those environmental risk factors, as well as, again, the factors of health in this milieu. And they create epigenetic changes, so changes in the ability of the DNA to be transcribed in certain ways that affect health across the entire life cycle. So again, attention to the importance of maternal health, including mental health. Another area in which we've made incredible gains are observational studies and the application of propensity score stratification. So statistical techniques that allow us to separate out the factors that go with the illness that affect reproductive outcomes from the effect of the drugs itself. So what we're doing is saying depression or psychiatric illness goes with psychotropic drug. These statistics allow you to create strata of patients that are more similar and allow you to take out the risk that is due to the drug itself. Over the last 10 years, this has been a huge help for our profession. The factors that are associated with the disease are called confounders, and those confounders, not the drug, account for the majority of adverse outcomes in SSRI-treated individuals, which provides, again, important information about these benefit-harm decision-making processes that we do. So miscarriage, stillbirth, fetal growth, birth defects, persistent pulmonary hypertension of the newborn, hemorrhage in the postpartum period, and preterm birth are all largely associated with confounding factors for mental illness and not the SSRI. There is one thing, neonatal adaptation signs, the syndrome that we look at in that post-birth period is not due to maternal depression. Our group and Amy Salisbury's group at VCU have shown this. So if a fetus is exposed near term to an SSRI, they are about 1.5 times as likely as an unexposed fetus to have respiratory distress, tremors, so difficulty feeding, and the admission to the NICU is again about 1.5 as much. So in a study we did, 8% of unexposed children went to the NICU, 12% of exposed went to the NICU. But importantly, there was no difference in the time they went home. So this respiratory distress that occurs in the ER often and results in a NICU admission tends to resolve very quickly. One of the major concerns has been, well, do these medications create neurodevelopmental risk? That's a lot what parents want to know. So this study is critically important. And what the investigators did was query a very large database, public and private insurance, millions of patients, 145,000 plus of antidepressant exposed and 3 million unexposed pregnancies. And what they did was they identified the exposure group and then tracked children in medical records through 14 years and looked for any diagnosis, whether there was any developmental problem, any psychiatric diagnosis, autism, ADHD, any kind of speech and language disorder. And then they compared the rates of those disorders in kids with the exposures. What they found was if you just looked at exposures with no propensity score matching, the offspring of mothers with mental illness were twice as likely to have these problems, which tells us that, again, these kids are at risk, things that we already know, but there was no association with the drug treatment itself. They also compared among siblings, drug-exposed and unexposed siblings, and found no relationship. This has been a critically important paper to share with mothers thinking about whether to be treated for severe depression in pregnancy. So we have a major challenge ahead of us in that we know that it's likely that exposure to SSRIs creates some risk, particularly neonatal adaptation. And we know that the psychiatric illness is shown to create a lot of risks as well. So what we have been asking in our literature has been, what are the risks of drug treatment? Is that what we really want to know? What we want to know is, what are the benefits and risks? But our studies are designed to identify risk. None of us would prescribe a drug if we didn't think the overall benefit was greater. But getting those data has been very difficult in the research questions we're asking. To answer that question, though, we need to have high-quality treatment of the mothers. We need to maximally reduce the disease burden. And in my opinion, that includes both therapy, skill building, and if necessary, pharmacotherapy. This is not showing at all the slide. So I'll tell you what the slide shows. Maybe, is it in, no, okay. So there are graphs on this slide that you can't see. And what we did was we followed a population of mothers who said, I need to stay on my medication through pregnancy because I can't function without it. And we followed them with the EPDS every month across pregnancy and postpartum. And then we put all the data in the computer and we said, are there patterns in this data, trajectories of depression? And there were 3 that you can't see. The lowest one was a group of women, about 18%, that had EPDS scores of around 2 all through pregnancy. Good, solid remission that sustained. The next group was a group I would call responders. They had EPDS scores around 5 through pregnancy. So better, but not remitted. Then there were 32%, almost a third of women who remained screen positive. So these were patients who were treated by members of our community in Chicago. And to me, I have to figure out, why is that? Are these people that just are not responding? Are the doses inadequate? What is happening? Because if you're going to use a drug, you'd like the moms to be well treated. So what I discovered was that in every community that I've worked in, primary care prescribers typically start with 25 milligrams of sertraline. And what I'm seeing over and over again are women who have been on 25 milligrams of sertraline for months, sometimes years, come in for consultation to me saying, I really think I need a new drug. This one's not working. And the ACOG guidelines, which I put up here, are critically important. So 25 is half the starting dose for most patients. And that was recommended to look at, is there some initial agitation side effect? It also helps reduce an initial increase in anxiety that particularly anxious mothers might have. So you try 25, but you go up to 50. And then iteratively, as side effects allow, you go up on the dose. The dose we found in our studies for remission, not I'm better, but remission, was between 100 and 150 milligrams. And this is an area that I think we need to attend to support primary care prescribers who are asking to screen with guidance and support. And I'm delighted with the perinatal access programs that are designed to do that in many communities. So I want to talk briefly about zuranolone, which is our new medication, a neurosteroid. When it first came out, I wanted to understand how does it compare to sertraline. So what you see on the right are data from a study I did years ago, which is a randomized trial with the rapid escalation to tolerance that I described for sertraline. And if we compare, it's a little tough, and I put the days on mine. So at 28 days, we have 27% remission for sertraline. And for a comparable time, say 21, we have 40% remission for zuranolone. After 56 days, we have 46% remission for sertraline and 55% for zuranolone. The point being that zuranolone is 14 days. The response tends to be sustained. And using that drug is becoming more common, but it's slow. The issues are that it's not available in many settings. It creates sedation and it's expensive. But it clearly is much more rapidly working than even rapidly escalating sertraline. However, both of the drugs get you to a remission rate of around 50%. So we need to understand how to use these drugs better and how to individualize treatment. So I'm going to finish with this slide that we all know the cost of untreated perinatal mental health disorders is huge, $14 billion. But I would argue that the emotional cost, the mom who is so emotionally dysregulated she can't care for her family herself is an incredibly greater cost. And I think all we have to do is listen to Emily's story and realize how these illnesses impact not only our moms, but our future generations. So thank you. Sorry about the initial, whatever's going on with my throat, but I really appreciate being here. And I thank you all for the work that you do.